Okay, this video is a book review. The name of the book is Overdiagnosed. And what we're going to do is it's talk about overdiagnosis in medicine. The author is a guy by the name of Gilbert Welch, and he's a physician. I actually have, here's a quick little picture of his YouTube channel. I'll put the link in that below afterwards. Here's the book, Overdiagnosed. He's the main author. He had some co-authors that helped him out with it. I'm going to come back to this slide in just a moment, but I want to give you some background information that'll help you to understand all this stuff. Because screening, you know, patients tend to love it. Patients think it's the greatest thing. It's an opportunity to win the lottery. They have no idea what they're getting into. Doctors tend to do it just because they feel obligated, okay? You know, and if they don't do it, they're afraid they're going to get sued. So they just, okay, this is the standard of care. Fine, we'll do it, all right? They don't want to get sued for failure to diagnosis, which could be a big pain in the butt, expensive. On the other hand, if you overtest and overdiagnose, hey, you generate more money for the system, and everybody's happy with you, and you can't get in trouble. Why not do it? Okay, and then big pharma and hospitals, they love it. Because what you're really doing here is you're taking a bunch of asymptomatic people. That's what screening is. Testing people who are asymptomatic. And it's like throwing a net on them. Like you have two people trying to make money for the healthcare system, and they're standing on the roofs buildings at a shopping mall. When people walk by, you throw a giant net on them and you trap them and say, you're not healthy people anymore. Now you are patients. You are our patients, and we're going to make money off of you. So again, patients think it's the greatest thing, but I got like 30 years experience with it. I think it's basically chump city. It's for chumps. I wouldn't do it. I don't do any of this stuff except the only things that I do, I'll tell you at the end what I think are worth doing. And it does vary a little bit from person to person, how much you're willing to discipline yourself to stay healthy. Okay, so imagine you had a giant farm. This comes from George Cryle, you know, and like at the Cleveland Clinic. He's a guy who sort of thought of this first. He described cancer as being three different things. You imagine you have a farmer. He has 100 square miles farmland. In the center, he has a fenced-in enclosure with three types of animals. He's got turtles, rabbits, and vultures. Now, a vulture is like a cancer that it gets out of the fenced-in enclosure, flies over the fence, and it just happens so fast the patient dies. There's nothing you could do. The thing about vultures are they're super rare. You know, when that happens, make a movie about it or something. It's so rare, you'll almost never see that. But you can't screen for it because it can occur in between screening intervals and kill the patient before you have a chance to do anything to successfully treat the patient. Okay, the next thing is rabbits. And rabbits are what everybody thinks cancer is. So the rabbit's in the central enclosure, it digs underneath the fence and it makes a run for it. You got to stop the rabbit, catch the rabbit, treat the rabbit. Okay, that's what people think cancer is all about. But here's the secret most people don't know. Most cancers are turtles. They're real slow growing. They're probably not going to kill the patient anyways. The patient's already old and sick and they're going to die of something else anyway. So why be so aggressive with it? All right. You don't even want to know. I mean, if you surgically removed all the men's prostates over 60, you'd be amazed at how many had cancer. And most of them, it's never going to bother them. Why should they even want to know? Okay. All right, and now here's the joke. The theme song of diagnostic radiology is Hotel California. You can check out, but you can never leave. You're never out of. Once you get, you know, the old joke is, what's the definition of a healthy person? Somebody who hasn't had a body CT yet. Body CT means CT, chest, abdomen, and pelvis. Because there's almost always going to be some incidental finding. There's going to be a lung micronodule, an adrenal nodule, a kidney cyst that might be, you know, neoplasm. Liver cyst might be a neoplasm. Pancreatic cyst might be a neoplasm. Sclerotic lesion on the bones, okay? There's a thyroid nodule. Send them for thyroid ultrasound. There's always more BS. Possible kidney mass or something in the spleen. I mean, it goes on and on, all right? So that's why you don't want to do this stuff unless you have a good reason. Oh, crap. I meant to, here we go. Here's what we want. This is the slide. Now we're going to talk about this in some more detail. And so, by the way, it was a good book. It was only 8 audio CDs. So what is that? About 10 hours in length. I think it's him narrating. And it reminds me of his voice, or the narrator sounds like him. And the narrator is pretty good. He had the right intonation, knew what he was talking about. And he's a very bright guy, this Gilbert Welch guy. He's smart. And he knows what he's talking about. And I can tell you, my experience, it matches his exactly. I mean, he knows exactly what he's talking about. And he considers it, Gilbert Welch said, overdiagnosis is the biggest problem in medicine. This book was written, I don't know, probably about 8-10 years ago, something like that. And there's bigger problems in medicine, but this is one of the big ones. I can tell you, I've been around in medicine for about 30 years. I've been a doctor, more than that. And I have seen entire departments double in size because they're doing this, maybe even triple in size. The number of doctors just keeps going up in the fields where they have the screening because it just generates tons of business. The more you screen for stuff, you take all these asymptomatic people and you turn them into patients, and then you start making money off of them. Okay, he says the biggest problem in medicine, because when you got a lot of experience, you'll see how many patients get screwed over by this. It's tons of them. And all this hubbub and fuss, there's been like no significant change really in cancer deaths. A little here, a little there. It's kind of a big joke. The big, battle against cancer started in the 1970s. There's been like so little progress in cancer treatment, it's not even funny. It's ridiculous. All right, types of screening. You can screen for coronary artery calcium, atherosclerosis of the heart. Look for a CAT scan of the heart. But in my opinion, it's stupid. If you ate the Western diet, meat, oil, processed food, you got coronary artery disease. It's guaranteed. Why radiate yourself with all that radiation to check for something you already know you got? Okay, the only time I've seen it be helpful is like a patient. A lot of patients are completely ignorant of science, and so they don't get it. You talk them till you're blue in the face about cholesterol, atherosclerosis, and they're just like it's just totally past them. All right, but then you show them a CAT scan. Look at this calcification in your artery. You're at risk for heart attack. Oh my God, So I can see it maybe in that sense, but why not show them a picture in the book? I just think it's pretty unnecessary radiating yourself. It's not like everybody knows this. I know doctor friends of mine who are pretty nice who've actually gone and got this scan, which I thought was kind of a joke because I don't know anything about nutrition. Lung cancer, chest CT. All right, so this is for the smoker. Well, why don't you just quit smoking and quit all your bad habits and become a low-fat vegan? That'll lower your risk more than anything. But as soon as you do one of these chest CTs, they'll do low dose, so it's not that much radiation, but now you start finding stuff. Kidney cyst, get a follow-up ultrasound. It's equivocal, get an MRI. All right. Then you start finding adrenal nodules, liver cysts, pancreatic cysts, all this stuff. Hiatal hernia, thickened esophageal wall, consult gastroenterology for endoscopy. It goes on. And that's why I joke about Hotel California. The first test might be a free screening test, but they probably got to pay for some of the follow-ups. And, in a private practice hospital setting, one after another after another. You could be stuck in follow-ups for 5 years. It's a big, expensive disaster, potentially end up with unnecessary surgery or something. And people think, well, what about the patients who are saved? What about the patients who are saved? And it is true, there are some patients who benefit from it. But a lot of times all it does is it gets you in the door for a worthless treatment sooner, okay? Prostate cancer, you can do the Ornish diet and control or lower your PSA in many circumstances. Why go through all this pain and misery when, a lot of the prostate surgeries are unnecessary. Guys are, exhausted from it for months, and then they often become impotent. Why put yourself through that misery when you can go low-fat vegan and probably get significantly better results from that based on my impression of studying it? That's what I do. I would never check my PSA because I think it's stupid. I just minimize my risk. Okay, what's the fastest growing specialty in medicine? Oh, that's kind of a bad joke, diseases of the female prostate. That's kind of like the latest joke going around. Okay, whole body MRI. Again, I think that's totally stupid. Just randomly looking for stuff. It all depends on pretest probability. If your pretest probability is really low, why would you go searching around for trouble? Because you're going to find a whole bunch of normal variants and borderline findings. There's not like a clear distinction quite often between normal, abnormal, insignificant abnormal, and really significant abnormality. A lot of times it's not that clear, so you got to keep following the lesion, and that can go on for years. Okay, plus there's other things you'd be better off not knowing about them, because once you know about them, there's all this pressure. Do a biopsy, do a surgery, there could be cancer. And even when it's like a bogus cancer, it's a turtle. Okay, colon cancer, we talked about that before. Dr. McDougall has lectures on that. Should you do a FlexIg? Should you do a colonoscopy? What's the risk-benefit ratio? What's your risk of perf in the colon, 1 out of 1,000 in that ballpark? What about the risk of bleeding after a biopsy, et cetera, et cetera? What about the risk of cognitive impairment from sedation? Probably real low. What about the risk of injury to the kidneys from the prep? Probably super low, but, if you can go low-fat vegan and lower your risk, I would do that. I did have colonoscopy in the past because my mom died of colon cancer and I was worried about it. But, the gastroenterologist told me my colon looked so normal, he said it wasn't even funny. And then I kind of saw all these people who would reverse their polyps by going low-fat vegan. I'm like, why don't I just do that? I would rather lower my risk in that way than have a tube up my butt. Okay, cervical cancer, pap smear. There's I'm not going to get into that too much, but it's a little bit dangerous. A woman could be made infertile because of that, or have, not necessarily infertile, but have a lot of problems with her uterus there. Okay, and the uterus is a very distinct thing about women. They say, okay, what's the difference between a man and a woman? A man has a Johnson, a woman has a Virginia. But another thing about a woman, besides having a Virginia, she's got a uterus, okay? I've seen a lot of them on ultrasound, CT, and MRI, okay? It's a very different thing than a guy's plumbing, okay? A woman's plumbing is very different. All this stuff like men and women are the same. No, they're not. Women got big pituitaries, the big convex upper surface. Men got small pituitaries, okay? That's like the only major difference I can tell in the brain. Other than that, a male brain, female brain looks about the same. Okay, let's see, breast cancer. The mammography studies show there's no benefit if the woman's, less than 40 years of age. Then you run into the dense breast, and also you have all these false positives. You freak the women out. Why not? Nobody ever teaches the women, avoid deodorant, avoid all these foods with estrogenic chemicals in them, filter your water. Nobody tells them that. Okay, they give them a pink ribbon to give money to the chemotherapy company when one of their friends has breast cancer. Nobody ever tells them how to avoid it themselves. I talked about that in the previous lecture. OB ultrasound scares the crap out of women, okay? Oh my God, then they're all worried they got a problem with their baby. And a lot of times they can't really tell what they're looking at. There's routine OB ultrasound, and then there's TIFAs, targeted imaging for fetal anomalies. But yeah, it can really scare the woman. Even some of the world's experts, like Dr. Welch talks about, a guy named Philly, a real famous ultrasound OB expert. And he's like, we're doing more harm than good, scaring the crap out of these women, stressing them out their whole pregnancy. Osteoporosis, bone mineral density, they compare it like to a young woman, and some of them it's like a 29-year-old Caucasian woman. Okay, why would a postmenopausal woman have the same bone mineral density when the pregnant young lady needs that to give to the babies, okay? Older woman doesn't need that much. And he makes the point, too, you'd be better off preventing falls. Well, how do you prevent falls? Eat a low-fat vegan diet so you get good blood supply to the brain. Okay. Pulmonary fibrosis on chest x-ray. That's some patients who maybe had chemical exposure, so you get a chest x-ray there. In and of itself, a chest x-ray is probably not that dangerous, but, you start getting a chest x-ray. All of a sudden, possible lung nodule, get a chest CT. Oh, there's a micronodule, and you're back down this whole path. If you're breathing well and your exercise tolerance is good, do you really want to do that? Peripheral vascular disease, well, the guy might have a lot of risk factors or might be, but if they're asymptomatic, do you really want to start testing that? That's not as big of a deal, but you get an ABI, ankle brachial index. Another big thing is previous smokers. They'll check them with ultrasounds for AAAs, abdominal aortic aneurysms. Okay, like I said, all these patients, they love all this stuff. Oh, they saved me from my cancer. Early treatment, isn't it wonderful? They think they're winning the lottery. Like I said, there's something called the Lollapalooza effect, a converging effect where everybody wants something. And like I said, they want it for different reasons. The patients think it's a good thing. Oh, I'm being proactive about my health. No, you're being stupid. Okay, the doctors to cover your ass, CYA, because they're afraid they're going to get sued for failure to diagnose if they don't do all this standard of care stuff. And then the hospital owners and the big pharma, they just love it. All these previously healthy chumps walking around the shopping mall, now they're trapped and they've become patients. We own their ass. We milk them every day for money. Keep them coming back. Got to keep coming back for more testing, more medications, more surgeries. Okay, more money for the hospital. Okay, they also make hospital grades. Say, well, if you want to be the highest hospital grade, what percentage of your patients are you screening with, ultrasound for aorta aneurysms? Are you screening for mammography? Are you screening with colonoscopy? So the hospital is pressured to do all this stuff. It's a way to force them to do all this stuff, whether they want to or not. Oh, if you don't follow the screening guidelines of standard of care, you're a bad doctor, you're a bad hospital. So they're like, okay, fine, we'll do it. Okay, and meanwhile, it's just a giant moneymaker pushing all these people into all this stuff. Most patients I've seen are just real passive. Whatever the doctor says, oh, you're the expert, whatever you say. Yeah, right. They don't understand. They have no idea what they're getting into. Okay, screening, like I said, can't diagnose, differentiate a turtle from a rabbit, so it'll just keep on sending the patient for follow-ups to get a time course on it. And that can be a lot of follow-ups over a course of years. Can cost the patient a lot of money, a lot of needless anxiety. It can bankrupt them, unnecessary treatments for bogus disease and give them complications. Like Gilbert Welch had a friend, the guy friend of his, who went and got his PSA checked, and then they diagnosed him with cancer, and it was probably a turtle, but he was scared, and he had his prostate surgically removed, and then he became impotent. So I think the guy was young, I forget exactly. I think he was in his early 50s or something, and he lost the service of his Johnson. All right, let's see. the patients always have a tendency to assume, well, if I only get diagnosed earlier, then I'll live longer or they could save me. What they don't understand is for a lot of cancers, there is no treatment. There's no treatment that works. There'll be some bogus treatment that's tried, but there's nothing that works. There's nothing that makes any difference. So all you're doing is potentially, sometimes the treatment is worse than the disease. You're volunteering for early unnecessary surgery or chemo that can make you die sooner and certainly make you suffer a lot sooner. Don't get me wrong, there's some cancers where there's a good treatment, but I'm just saying, be careful. Think about it a lot. Study it a lot. Get an unofficial opinion where no money or bias is involved. Once you go to a doctor or a specialist, quite often, let's say you're in a private practice hospital, you are referred to that specialist. There are expectations based on the standard of care, which almost always is treat as much as possible. So the referred doctor has to go by that. That's the advantage of talking to somebody off the record and just getting an opinion. Like if you know a doctor, you have a friend who's in the business or something, they can just tell you, hey, I would do it or I wouldn't do it. And that's going to be more valuable than a paid for official opinion where they have to go by the standard of care. Otherwise, they can get in trouble. Otherwise, they'll piss off their referral. So those opinions are biased. Let's see, prostate surgery. Yeah, well, you really want to know that so you can get your prostate surgically removed unnecessarily, make yourself impotent. Stupid. You got, Ornish diet, which has got great results. Yeah, that was for low grades, and you don't know if you have a high grade, but high grades are relatively uncommon compared to low grades. Having needless anxiety. So the person who's got one of these incidentalomas, probably normal variant things, they've got like the sword of Damocles hanging over their head. They're all worried. Sometimes they're worried for years. Like I said, you can have big medical bills from this. You can go bankrupt from this. You have lead length bias, meaning that if two people have the same disease, let's say the same cancer that's going to kill them, okay, if one of them diagnoses it when it's real small from screening, the other diagnoses it later when they have symptoms, they might die at the same time. Like let's say they both were going to live to 70, all right? So it seems like, well, one of them was diagnosed at 62 and lived to 70. The other one was diagnosed at 68 and died at 70. So, well, geez, so-and-so only lived 2 years after cancer. This other guy lived 8 years. But it really made no difference. It's called the lead length bias. By diagnosing early, the patient seems to live longer, but it's simply the cancer still might have run its natural course. What I'm getting at is, the benefits for these things are totally exaggerated because people don't really understand that concept. And the risks are very much underestimated by people. Okay, like I said, I've been in this business over 30 years, and I can tell you, I would never go for any of this stuff that I listed here. Okay, all these screening things. What would I do? What do I think is good? Blood pressure. It's worth it to know your blood pressure. Okay. What they do too is they lower the thresholds to treat. It used to be the threshold to treat blood pressure is in the ballpark of 160 over 100. Nowadays, it's often 140 over 90. And the point is, when you lower the threshold to treat, you get tons more patients. For Big Pharma, that's millions of patients. That's lots of money for all these pharmacies, all these hospitals, okay? And then the patient has to keep coming back, so you keep making money on them, finding more problems, inducing complications, treating the complications. Fasting blood sugar for diagnosing type 2 diabetes used to be 140. Now it's 126. So again, once you lower that threshold, now you got lots more patients to treat, okay? But I would still want to know those things. I just wouldn't jump into treatment. Total cholesterol, I think it's good to know that. You could, if you want, check LPA. I just did that because a friend of mine had an issue with his, so I was curious what mine was. I wasn't really that worried about it. Vitamin B12, it's good to know about that, especially if you're low-fat vegan. Serum ferritin, I like knowing about that because it's very easy to control that and get that decreased. You want to watch out for how they describe risk to you. Often they're describing relative risk, and relative risk can be super inflated. They can make something sound wonderful even when it's nothing. Absolute risk is more like, what's the absolute risk? So the point is, if a disease is super rare, it only happens 1 out of 10,000 people, a giant relative risk can be essentially meaningless, all right? On the other hand, if there's a very high risk of something, then it's more useful to look at that closely, let's just say. The best data for unbiased information to be provided is quite often a randomized clinical trial, but those are often not available for lots of things. So anyways, is the book worth listening to? Yeah, I found it was very enjoyable. It was very well written, very well done. I think it's true. It's accurate. I'll put the link for his YouTube channel if you want to watch those below. So anyways, it's an excellent book.